Cystic fibrosis. Cystic fibrosis is an autosomal recessive disorder caused by a mutation in the genes that code for chloride transport called the cystic fibrosis transmembrane conduction regulator (CFTR). Mutation in the CFTR gene damage chloride and water transport across the apical surface of epithelial cells and exocrine glands throughout the body. This leads to abnormal thick mucus in the lungs as well as damage to the pancreas, liver, sinuses, intestine, and urinary tract. Neutrophils and cystic fibrosis dump tons of DNA into airway secretion, clogging them up. Damaged mucous recurrence decreases the ability to get rid of inhaled bacteria. Presentation includes a young adult with chronic lung disease, cough, sputum, pneumonitis, bronchiectasis, wheezing, and dyspnea, and chronic episodes of infection. Other symptoms include sinus pain and polyps common, GI involvement, meconium illness in infants with abdominal distension, pancreatic insufficiency, 90% of cases with steatoria and vitamin A, D, E, and K malabsorption, recurrent pancreatitis, distal intestinal obstruction, biliary cirrhosis, genitourinary involvement, men infertility, azoospermia very common, with definite missing, 20% of cases, women infertility because chronic lung disease alters the menstrual cycle and thick fluid mucus blocks sperm entry. Cystic fibrosis lung disease accounts for 95% of deaths. Acids are spared, beta cell function is normal until much later in life. Diagnostic tests include increased sweat chloride test, most accurate test, pilocarpine increases acetylcholine with increased sweat production, genotyping with CFTR less accurate than sweat chloride level because there are so many types of mutation genes to cystic fibrosis. Test X-ray and CT. Hosting abnormality on any other test will confirm diagnosis. Bronchiectasis, pneumothorax, scarring, atelectasis, hyperinflation. Arterial blood gases may show hypoxia, anemia, and in rare disease cirrhosis. Pulmonary test shows mixed obstructive and restrictive pattern, decreased FVC and total lung capacity, and decreased TLCO. Sputum culture, non-typable Haemophilus influenzae, Pseudomonas aeruginosa, Staphylococcus aureus, Burkholderia capacia. Chloride levels in sweat greater than 60 mol equivalent per liter on repeat testing establishes the diagnosis. Treatment: antibiotics, eliminating colonization is difficult, and sputum culture is essential to guide treatment. Inhaled aminoglycosides as a treatment method are almost exclusively limited to cystic fibrosis. Inhaled recombinant human deoxyribonuclease to break down the massive amount of DNA in respiratory mucus that clogs up the airways. Inhaled bronchodilators such as albuterol. Pneumococcal and influenza vaccines. Nations. Pancreatic enzyme replacement. Lung transplantation only have no response to medical therapy. Tizarcaptor and ivacaftor in combination will help the 90% of patients who have some type of F508 mutation. Lung infection, pneumonia, community acquired pneumonia. Community acquired pneumonia (CAP) is pneumonia occurring prior to hospitalization or within 48 hours of admission. It is among the top 10 causes of death in the U.S. The most common cause of community acquired pneumonia is Streptococcus pneumonia. However, the environmental reservoir of Strep S pneumonia, the method of acquisition, are not known. Other pathogens related to CAP are follows. Common pathogens and CAP and their associations. Pathogen association: Haemophilus influenza, COPD, S. aureus, recent viral infection, influenza, Klebsiella pneumonia, alcoholism, diabetes, anaerobe, poor dentition, aspiration, Mycoplasma pneumonia, young healthy patients, chlamydia pneumonia, hoarseness, Legionella, contaminated water sources, air conditioning, ventilation system, Chlamydia psittaci, birds, Coxiella burnetii, animals at the time of giving birth, veterinarians, and farmers. Presentation with all forms of pneumonia include fever and cough, rales, bronchi, and crepitations are common respiratory findings. Dyspnea seen with a severe infection, change or rigors, a sign of bacteremia, often with bacterial pathogen. Hypothermia just as bad as fever in terms of pathologic significance. Abnormal vital signs, tachycardia, hypertension, tachypnea, or mental status, seen with severe infection. Cough from any etiology may be associated with hemoptysis. Dullness to percussion if there is an effusion. Bronchial breath sound and ergophony due to a consolidation of air spaces. Abnormal pain or diarrhea from infection of the lower lobes irritating the intestine through the diaphragm. Chest pain from inflammation of the pleura. Dry non-productive cough seen with infections that preferably involve the intestinal space and leaves the air spaces of the alveoli empty, explaining why there is less sputum production. There are mycoplasma, viruses, Coxiella, pneumocystis, and chlamydia. Dyspnea, hyperview, and abnormal chest X-ray are the main ways to distinguish pneumonia from bronchitis. Chest pain from pneumonia is often pleuritic, changing with respiration. Tips: Yosemite Step 2CK may play abnormal breath sound as a part of multimedia and ask you to recognize them. Organism specific association on presentation. Pathogen association. Klebsiella pneumonia, pneumonitis from necrotizing disease, current jelly sputum. Anaerobes, foul smelling sputum, rotten eggs. Mycoplasma pneumonia, dry cough, rarely severe, plus laryngitis. Legionella, GI symptoms, abdominal pain, diarrhea, or CNS symptoms such as headache and confusion. Pneumocystis, AIDS with less than 200 CD4 count cells. Diagnostic testing is as follows. Chest X-ray best initial test can be falsely negative in 10-20% of cases. Sputum, gram stain, and sputum culture to identify a microbial etiology. Many organisms are not detected on sputum stain or culture. Atypical pneumonia refers to an organism not visible on gram stain, 30-50% of cases, and not culturable on standard blood agar. Sputum stain and culture have low sensitivity. That is because mycoplasma, Chlamydophila, Legionella, Coxiella, and viruses are not visible on gram stain. Specific sputum colors are useless for determining an etiology. Leukocytosis and where WBC is often present but non-specific. Chest X-ray, bilateral interstitial infiltrates are seen with mycoplasma, viruses, Coxiella, pneumocystis, and chlamydia. Same organisms are typically present with a non-progressive cough. X-ray lags behind clinical findings. In some cases, first chest X-ray can be false negative. Chest CT and MRI show greater definition of abnormalities found on chest X-ray but will still not be able to identify microbiologic etiology. Blood culture is positive in 5-15% of cases of CAP, community-acquired pneumonia, particularly those with chest pneumonia. It is impossible to identify the cause of pneumonia from the history and treatment alone. The first chest X-ray can be falsely negative in 10-20% of cases. Specific diagnostic test per organism. Organism diagnostic test. Mycoplasma pneumonia, PCR, code agglutinins, serology, spell culture, media, Chlamydophila pneumonia, rising serologic titers, Legionella, vein adhesion, culture on charcoal yeast extract, Chlamydia psittaci, rising serologic titers, Coxiella burnetii, rising serologic titers, Pneumocystis jersey, bronchoalveolar lavage. Treatment is often initiated without having a specific organism, and in fact, it is the severity of disease, not the etiology, that drives initial treatment. Severity of pneumonia, not etiology, drives initial treatment. If an exam question describes an organism on gram stain, then direct treatment towards that organism. In the initial management of pneumonia, the most important step is usually determining the severity of disease. There, it can be decided where to place the patient, that is, inpatient or outpatient. If there is no response or the etiology is unclear after initial treatment, do the following. Phagosynthesis, analysis of pure fluid through infusion to determine the presence of an empyema. Analyze any new large effusion. Look for LDH greater than 60% serum level and protein greater than 50% serum level. PMNs, polymorphonuclear greater than 1,000 per microliter, or pH less than 2% but is suggestive of infection. Empyema will improve more rapidly if drained with a chest tube. Bronchoscopy really needed in CAP, community-acquired pneumonia if there is severe disease unresponsive to empiric treatment and requiring intensive care. An exception is pneumocystis pneumonia, where non-invasive testing rarely reveals a diagnosis, and precise confirmation of the etiology is critical to guide treatment. New large effusion secondary to pneumonia should be tapped. The far majority of pneumonia cases can be treated outpatient with oral antibiotics. Severe cases requiring hospitalization must have all of the following conditions: hypertension, systolic less than 90 mm mercury, respiratory rate greater than 30% per minute, or pressure of oxygen less than 60 mm mercury, pH less than 7.35, burn greater than 30 mg per liter, sodium less than 130 mmol per liter, glucose greater than 250 mg per liter, pulse greater than 125 per minute, confusion, temperature is greater than 40 degrees Celsius, age greater than equal to 65 with comorbidities such as cancer, COPD, CHF, renal failure, and liver disease. Either hypoxia or hypotension alone is sufficient reason to hospitalize the patient. Figure 4.4 right middle lobe infiltrate parasitic or bacterial pneumonia. Minor figure separates the middle and upper lobe. Right middle lobe infiltrate consistent with bacterial pneumonia. Nifamulin, pleuromotilin antibiotic, inhibits ribosomes used in community-acquired bacterial pneumonia. Use of moxifloxacin in community-acquired pneumonia. Omadacycline, tetracycline derivative, community-acquired pneumonia, and methicillin-resistant Staphylococcus aureus. Q4.5 intestinal filter leaves the airspace empty. This chest X-ray can be consistent with pneumocystis, pneumonia, mycoplasma, virus, and chlamydia. Tip: infectious disease serologic test is never the most accurate test. Figure 4.6 Outpatient and inpatient treatment of community-acquired pneumonia. Outpatient treatment, inpatient treatment. Outpatient treatment: previously healthy or no antibiotic in past 3 months and mild symptoms, macrolide, azithromycin or clarithromycin or doxycycline. Comorbidities or antibiotic in the past 3 months, respiratory fluoroquinolone, levofloxacin or moxifloxacin. Inpatient treatment: respiratory fluoroquinolone, levofloxacin or moxifloxacin or ceftriaxone and azithromycin. Tip: almost all infectious diseases are initially treated empirically, that is, without a specific etiology. Mycoplasma and chlamydophila are rarely confirmed because they are simply treated empirically. Chest X-ray does not guide care admission. X-ray cannot reveal the severity of hypoxia.